I'm not too sure if people are in yet. All right, everyone, it's 12 noon, so happy afternoon. I hope my audio sounds okay. Dr. Teris, want to give me a thumbs up, thumbs down? Is it still shaky? All right, well, again, thanks for joining, everyone. This is our second ever Lunch and Learn, so very excited to be here. My name is Alexa Carey. I'm the Partner Relations Coordinator for both the South and the West RPU. So just wanted to give a quick little, housekeeping item before we get started today. There is a question and answer box at the bottom of your screen. There will be a question and answer period. So feel free to add any questions in that box and Dr. Teris will address them. Additionally, I believe you have the ability to raise your hand. So should you feel the need to raise your hand, please feel free to do so. And without further ado, I'm going to go ahead and introduce Dr. Teris. Many of you may know him, but just want to give you some insightful information on Dr. Teris. So Dr. Teris is our Chief Medical Officer at Care Compass Network. He earned his Bachelor's of Science degree in Biology, magna cum laude, from the University of Pittsburgh at Johnstown in 1973. His Doctor of Medicine degree from the University of Pittsburgh School of Medicine in 1979. And a graduate certificate in biomedical informatics from Oregon Health and Sciences University in 2011. Dr. Teris completed a family medicine residency at Washington Hospital and is a board certified in family medicine. He has been named as a fellow of the American Academy of Family Physicians and is credentialed as a certified physician executive by the American Association for Physician Leadership and Certifying Commission in Medical Management. After residency training, Dr. Teris began his career as a family physician and a chief of family service practice at Air Force hospitals in North Dakota and Virginia, receiving a commendation medal while on active duty for 4 years. He was then the emergency physician at Walter Reed Memorial Hospital in Virginia, before moving to Binghamton and working with associates in medicine at and UHS Medical Group as a family physician for the next 27 years. He subsequently was a physician advisor and chief medical information officer at Ascension Lourdes Hospital prior to joining Care Compass Network in 2017. So without further ado, I know Dr. Teris has a super lengthy and descriptive presentation on COVID-19. So without further ado, Dr. Teris, pass it to you.
Thanks so much, Alexa, and welcome everybody to the Lunch and Learn. So as Alexa alluded to, we're going to do a COVID-19 update. You know, we're in the midst of an infodemic as well as a pandemic, and there is just a load of information and misinformation out there. It seems to change by the minute and by the hour. So what I try to do in these presentations is really distill it down and present the data and present the science in an understandable way. So there are so many different aspects of this. I just called it a pandemic potpourri, and we can't obviously in a brief lunch hour really look into everything in great detail, but on the slide you'll see what I'd like to at least highlight today in the presentation. Based on feedback from partners and questions I've been asked all along. So first of all, people ask, well, how do I tell if I have COVID-19 or if it's the flu or a cold or an allergy? So we will address that a little bit. You have seen also in the media, perhaps an update recently as far as CDC recommendations for quarantine, and we'll look into that a little bit. I certainly would like to talk about holiday gatherings. We've just gone through one. We're going to go through another, and there are a lot of important points to be made. I would also like to discuss a little bit of the science in terms of droplets and aerosols, disease transmission, and just the simple things we can really do based on science and based on data. And finally, of course, a very important topic now is in terms of vaccines, and I would like to provide an update. So flu versus COVID versus colds versus allergies. This is sort of a graphical representation of the symptoms. Now, the caveat here is if you look at the CDC website and you look at the possible symptoms of COVID-19, it runs the gamut, and particularly for children, it's all the stuff they get from now until the spring. It can be anything from nasal congestion to scratchy throat, cough, of course, even gastrointestinal symptoms, etc. So, you know, seeing patients as a clinician, this is really a challenge. So somebody comes into the office and they've got a fever and they're achy and they're coughing and maybe have a little bit of a headache and they're tired. I can't clinically tell in most cases whether they have COVID or the flu. Now, if you look at the graph, you'll see red dots, orange dots, yellow dots, etc. And if you focus on the red dots, these are the most common symptoms of each disease entity. So if you look at COVID-19, obviously cough, fever, as it gets worse, shortness of breath. Of course, other symptoms, sore throat, body aches, headache can occur. Less commonly, runny nose, sneezing, things like that. Although in yellow is diarrhea, and I have heard more and more in terms of GI symptoms, sometimes presenting as the only symptom. Now, if you look at flu or influenza, a lot of the same stuff, right? Cough, fever, body aches, headache, fatigue. But on the left side of the slide, this is the differentiator, and there is a profound and sudden loss of taste and smell in 40 to 60% of COVID-19 cases. So if somebody has flu-like symptoms and they've also suddenly lost taste or smell, in my mind, it's COVID until otherwise proven. And this isn't, you know, you've all had colds or allergies and maybe the taste and smell gradually reduce a little bit. This is really profound and can be long lasting. Now, looking at colds, it's more scratchy throat, runny nose, maybe some body aches, sneezing, and allergies is more runny nose, sneezing, watery eyes. So there are some differentiators here. But if you take one thing away from this, it's that loss of taste and smell. So you'll say to me, well, most people are wearing a mask, we're washing our hands, we're doing all this stuff, and I know people are still getting colds. Why is that? Well, The common cold is caused by a lot of different viruses, and I have a listing here, and you'll even see, oddly enough, coronaviruses. There are other coronaviruses that do cause colds. And the thing that differentiates this is cold viruses last much longer on surfaces, and also they're much more infectious. So in distinction to COVID-19, which is usually spread through respiratory secretions, colds are more commonly spread by touching surfaces and then touching the face. So, we've all heard that, wash your hands, don't touch your face. That is relevant for COVID, much more relevant for colds. And the other differentiator is cold viruses can last a long time on surfaces. Some of these adenoviruses can last 3 months. And where children congregate, it's a petri dish, folks. We all know that. So that is why people are still getting colds. And, as I watch people and I go to webinars, people have a mask on and they're constantly touching that mask. It's just human nature. So we got to be careful. Okay, so what's the other thing you hear out there all the time? COVID-19 is just a flu. It's just a cold. It's no different. Everybody's panicking. They're a bunch of sheep. Well, no, absolutely not. Something called the infection fatality rate. So what that is the known and unknown cases. So we estimate for every case that we know of, positive test, has symptoms, there's probably 5 to 10 cases out there that we don't know about. So this takes into account those unknowns. So for COVID-19, the infection fatality rate's about 1%. For influenza, it's certainly less than 0.1%. It's at least 10 times as deadly. And if you see a case fatality rate, getting into the weeds a little bit, the case fatality rate is really the proven cases and the death rate. And that will be higher, of course, because we're not taking into account all those unknowns. So you'll see case fatality rates in the range of 3% for COVID-19. So again, COVID-19 versus the flu. COVID is much deadlier. In spite of all the stuff you see on Facebook and hear out there, since December of last year, it's killed more people in the United States than influenza has killed in the last 5 years. It's much deadlier. Again, this is a novel virus. There's minimal, if any, pre-existing immunity. There's some work out there looking at immunity from other coronaviruses, and that may be the case. We just don't know at this point. The treatments are improving. We're learning more and more all the time, and we're working to validate a lot of the therapies, but of course we have a lot more experience with flu. And finally, a big difference is you've heard about so-called long haulers. These are people that have a wide variety of long-term effects. These are multi-system, neurological, cardiac, et cetera. We're still learning a lot about that, and that differentiates COVID from the flu. And I really want to delve into the flu a little bit. And I would urge you, if you haven't had your flu shot yet, after this lunch and learn, get online, go to the CVS website or any of the pharmacy websites, fill out the form and go get your shot. And don't procrastinate. This is so important. So when you look at Influenza Activity 2020, which refers to last year, not this year, then okay. There were 2 overlapping waves. There was so-called influenza B and then a type of influenza A. Last year, there was significant amount of pediatric deaths and high hospitalization rates, and we don't know at this point if it'll carry on to this year, but what will be the impact of COVID-19? Who knows at this point? This is all new. The Institute for Healthcare Improvement has a Healthy People 2030 objective for influenza. These are data-based national landmarks that we're going to try and achieve. And basically by 2030, we want to increase the proportion of persons who are vaccinated against flu to 70%. And you say to yourself, what? We don't have 70% getting immunized? Well, no, unfortunately. So let's look at pediatric coverage. So if you look at the entire 6-month to 17-year age group, and this is numbers from a few years ago, about 62%. If you look at the little folks, the 6-month to 4 years, usually they get in for their well child visits for the most part, we hope, and they have about 73%, but it's nowhere close to 100. And as you look at the 5 to 12-year group and the 13 to 17-year group, look what happens. By the time they're teenagers, we're down to maybe half of them being immunized. This unfortunately is true for healthcare in general for that age group. So we're well below 70%. Adult coverage. So we've got, let's see, over age 18 years, 45%. Over 65, the frail group that really needs it, 68%. But look at the 18 to 64 and the 50 to 64 range, 39%, 47%, and even people in those middle ages with high risk medical conditions, not even half are immunized against the flu. And that's a pretty sad situation. What about healthcare personnel? Well, people do pretty well in the hospital. They're pretty much required, as a condition of their job, unless there's an overriding reason they can't. Out into the ambulatory setting, now we're down to about 80%, but this is what's pretty sad. Long-term care settings, and these are the highest risks, and now we're down to about 68%. And that's not something that's really acceptable to me. Looking more deeply at healthcare personnel, physicians, nurse practitioners, nurses, pharmacists are pretty good. Other clinical personnel, pretty good. But let's look at assistants, aides, and non-clinical personnel. And I would think this is likely in the skilled nursing and long-term care setting. And they're down to 72, 75%. So we have a long way to go. It's very important. There are a lot of myths about the flu and the flu shot. I've heard them for years. I've had a multiplicity of conversations with patients. Let's see, the flu shot will give me the flu. Well, no, it won't, because it is not a live vaccine. You cannot get the flu from the flu shot. Now, again, the caveat here is that you will get a flu-like illness, maybe some muscle aches, low-grade fever, a headache for a day, maybe 2 days. This is not the flu. This is a good thing, believe it or not. That's your immune system responding to the immunization. I'm healthy. I don't need a flu shot. Well, every year, healthy people get sick, and some even die, okay? Some people have underlying conditions they don't know of. But even if you have a mild case, you can certainly pass it along to others, and many of them may have a number of conditions that are important to know about, and could cause significant damage. I've never had the flu. Well, every year about 1/5 of Americans get the flu. That's about 60 million people, and a lot of them never had the flu. In my mind, it's sort of like saying, I've never had a car accident. I don't need auto insurance. It's not a valid argument. And here's the one you hear all the time. The flu shot doesn't work. I know my neighbor, my aunt had the flu shot and they still got the flu. Well, influenza vaccine, what's particular to that is it's guesswork each year as to what the exact strain will be the following year. So they do their best and usually hit it pretty well. In most years, the flu vaccine is probably 45 to 70% effective, somewhere in there. But from the standpoint of both population health and reducing the incidence across the population, and also your own personal health, even if it's partially effective, it will still, in most cases, reduce or attenuate the symptoms. So that's not really a valid argument. In fact, that's an argument for more people getting immunized, because if it's 60% effective, but 80% of people get immunized, we have much more, and here's the buzzword, herd immunity that we hear about. So very important. So just to summarize, why is the flu shot so important? Well, here's something I would not look forward to. You can get flu and COVID-19 at the same time, and we haven't had experience with this yet, and I don't look forward to finding out what that does to people, but it can happen. If you're watching the news at all, you're seeing what's happening in other areas of the country, particularly the Midwest, Southwest, North Dakota, South Dakota. Their hospitals are getting overwhelmed already. And we're not even into flu season here. This is kind of what happened in New York at the beginning. Certainly, if both rage this year, we could overwhelm the system. We could overwhelm testing capacity. Now, another distinction between flu and COVID is that flu hits children hard, and it spreads very readily in the schools. We're doing everything we can to keep the kiddos in school, and let's get them immunized, and let's get immunized so we can reduce that incidence. And finally, at this point, any reduction at all in disease severity and prevalence will help. So very important. I'd like to pivot now into holiday gatherings. Well, we've just been through Thanksgiving. You can see the depiction of Thanksgiving on the left side of the slide, not Norman Rockwell, but is 2020. There is a learning moment here. If you look, who sees an educational moment? Well, what I'll tell you is it's the gentleman at 12 o'clock. He's got his nose sticking out, and that doesn't work. You got to wear the mask over the mouth and the nose. But now we've got other holidays coming up, and this is really a crisis because we're now spiking, and now we've got yet another opportunity for gatherings, and New Year's is around the corner, and that's another opportunity. And you're probably more likely to see this than to see people 6 or 10 feet apart wearing a mask in small groups. So folks, we have a problem coming. There's a lot of misinformation out there. Sometimes we have to laugh a little bit. And, here's a here's a study. Study confirms nose holds connect to lungs. Below the nose mask wearers are shocked by the science. And what I say to people when I see them wearing the half mask is, okay, when you go to get the COVID test, where do they stick that swab, right? Up your nose, because that's where the virus is. So again, the mask should be worn and should be worn properly. So Thanksgiving, let's talk about that a little bit. So Canada, for those who didn't know, our neighbors to the north celebrated Thanksgiving on October 12th. They're having the same social issues we are. If you look at the picture on the left, this is in Canada, this isn't the United States. Oxygen is essential. Kind of like you put a mask on, you don't get oxygen. False. There's a little sign on the left, no mask, no vaccine, and they even threw in no 5G. Somehow, the cell towers are related to this too. But at any rate, in Canada, where people tend to be a little more compliant than they are here, there was still a huge national spike in cases. Records were shattered after Thanksgiving. One of many examples, there was one Thanksgiving party with extended family, led to 10 cases, 3 babies, 4 in another household, 2 in a workplace, multiple people hospitalized. So we unfortunately didn't learn from this. And here are the United States metrics. So up, right? Now, what we've heard from some of the purveyors of false facts, well, the cases are going up because the tests are going up. Well, there's some truth to that, but look at that. Look at the second from the right, currently hospitalized. So you'll see low tests, low cases, but high hospitalized. And the hospitalized group is the group you really need to look at. We weren't picking up a lot of those cases, but nevertheless, a lot of people were ending up in the hospital and then they turned out to have COVID. So, but as you can see, everything's exponentially increasing now. You look at the paper today, we've set records for everything, and it's only going to continue to go up for a while. And the good news is, even though the hospitalizations now are higher, if you look at the death rate, it's a little lower, and that's based on what we're learning about therapeutics. Not ideal, but we're learning. So, holidays, potential super spreader event, why is that? So there's a neat little protocol or acronym I like to run this through, and this is stay smart. Okay. So S stands for space. Are there lots of people closer than 6 feet? Dangerous. M stands for mask. I don't think most people wear a mask when they're eating or drinking. And one of the commonalities in super spreader events is eating and drinking. A is for air. Are you going to be indoors in an enclosed space, poor ventilation? Not good. R is for restrict. You got to restrict the group. If it's not small, the more the merrier, but the more the most dangerous, right? And time. Holiday gatherings are likely an extended affair. So what you want to do is, keep the meal short, stay apart, et cetera, et cetera. And the CDC has published some nice risk considerations and recommendations. So what are the risk considerations for the holidays? Every day you assess your own risk. Will I wear a seatbelt or won't I? Will I drive 80 miles an hour or 50 miles an hour? You're assessing risk and you're basing your actions on your assessment of that risk. So let's look at this. So where's the gathering? Community levels. We had a pretty significant spike here in the southern tier. It's improving a little, but it's still up there. We're still up around a 3 to 4% positivity rate. Where is the gathering? Most of us are not going to have Thanksgiving and Christmas and New Year's gatherings outdoors here in the southern tier. So indoors is riskier. What is the duration? Longer is riskier than shorter. How many people will be there? More is riskier. Where are people coming from? There are lots of websites out there where you can look on the website and see exactly what's going on in that vicinity. So, you know, if Aunt Bessie from North Dakota wants to come and celebrate Christmas, I'd probably tell her to stay home at this point. What's the behavior of the people that are attending? Are they social distancing? Are they washing their hands? Are they masking? You don't always know what other people are doing. And what's the behavior of attendees during the gathering? And we went over that. And as I go through the presentation, there will be some links on the slide deck. And what we can do is make a PDF version available, because I am going to refer you to some of these links as we go along. CDC recommendations for the holidays. So people who should not attend in-person holidays. Well, if you have COVID-19, probably shouldn't, right? If you've had it and haven't yet met the criteria for when it's safe to be around others, probably shouldn't. If you have symptoms, any symptoms, remember what I said before, you can have anything from nothing, 30 to 40% of people, no symptoms, to a stuffy nose, to GI symptoms. Anybody who's not feeling 100% shouldn't be there. If you're waiting for test results, you probably shouldn't be there. If you think you've been exposed to somebody in the last 2 weeks, if you or others there are at increased risk of severe illness, you shouldn't be there. And, you know, as it says on the bottom, if you're at increased risk, avoid in-person gatherings with people not in your household. And I hate to say this, but this includes your friend down the street, your aunt and uncle that live 20 miles away. They're not in your household. And avoid large gatherings. So what do? You know, this really stinks. How much risk are you willing to take? Well, is there a way to make these gatherings completely safe? And of course, the answer is no. As I just said, 45% of people have no symptoms at all. So I've heard, oh, we'll take everybody's temperature. We'll ask them if they've been feeling sick. A normal temp does not guarantee the person's not infected by any means. And testing does not guarantee that the person's not infected, because I'll go into this a little bit further, but certainly depending on where you are in the continuum, the testing can be false negative. Will strict precautions while traveling make it safer? Well, yeah, maybe, but you know, traveling is traveling, and you are exposed to a lot of people. And is there a data-driven way to make holiday gatherings safer? Well, the most important and probably not realistic way is for everybody that's going to be there to strictly quarantine for 14 days before the gathering. Now, the 14 days may be different now. I'll talk about that in a minute, but for purposes of this discussion, 14 days. So count back from Christmas or New Year's, 14 days. Everybody stays home. It means you don't go to the store, you don't go out, you don't go anywhere. You're quarantining. And nobody comes if they have any symptoms, and you limit the numbers, and you go outside, keep the sit-down meal short. Very, very tough. Excellent article. I've linked at the bottom here. Take 10 minutes and read it, and it really will go through this thought process in more detail. This is a timeline. It's a little bit of a busy slide, but what I'm trying to get at here is, if you look at the left where it says exposure, the symptoms begin somewhere 2 to 14 days after exposure, but the infectious period begins even before symptoms sometimes. So 1 to 12 days after exposure. So what happens here is you could be infectious, you can feel fine, you don't have a temp, you could even have a negative test, and you still got a problem here. So I did put an asterisk here, and I'll talk about this in a little more detail in a moment, but CDC just came out with some new recommendations. They fully endorsed the 14-day quarantine, but just for logistical purposes, people are not complying. They're not being honest with the people from the health department, the contact tracers, because they don't want to quarantine for 14 days. So based on data, based on science, there are some other options. This is up to your local health department authorities, however, based on what's going on in your community, but 7 days with a test or 10 days without a test instead of the 14. But, we'll have to see what the local health departments have to say about this. Now, I'm going to credit UHS. This is an excellent slide, and this is Bob. And I teased our finance guy, Bob Carangelo, and told him he ought to be a little more careful. But this illustrates very nicely how the incubation works and how the exposure timeline works. So if you look on the left, this is what happens. I mean, one person, it just mushrooms out. Even if they're around 2 others, they're each around 2 others, they're each around 2 others, and look what happens. So on day 0, Bob was exposed to COVID-19, if you look at the right hand of the slide. And he was just wondering. So he went on day 5 and got the test, and it was negative. And he said, oh boy, I'm fine. So 3 days later, he thought he didn't have it. And he went to work and he went to a family gathering. But he was contagious already, right? Didn't have any symptoms. And on day 10, he became symptomatic and tested positive. So I think this very nicely illustrates the issues here. So how long to quarantine? 14 days, because remember, you can develop symptoms 2 to 14 days after exposure. But the CDC has looked at this, and this isn't random. They base this on data and on science, and they do recommend 2 possible options based on what's going on in your own community. 10 days without testing, 7 days with a negative test result within 48 hours before the end. So the negative test result should be on day 5 to day 7. Now, will you miss some people? Yeah, you will. Probably the 7-day scenario, you might miss up to 5%. The 10-day scenario, maybe 1%. But what they're balancing is what's realistic for people. And based on the data, you're still going to catch most. But even after stopping quarantine, be it 7 days, 10 days, whatever, you still want to watch for symptoms up to 14 days. If you have symptoms, isolate immediately, contact your healthcare provider and/or public health. Wear a mask, stay 6 feet away, wash your hands, avoid crowds, etc. And CDC well recognizes that any quarantine shorter than 14 days balances reduced burden against a small possibility of spreading. I did also put the link on there, and if you want more information, you can link up to the CDC website. And you talk about a contact. What is a so-called close contact? And this is interesting information. So this was based on partially on what happened up in a jail in Vermont, where there was a guard, and there were cameras all over the place, so they were able to trace his activities. And the guard was never exposed to any prisoner for more than a few minutes at a time. The guard came down with COVID. A lot of prisoners were positive. Well, what they found out was it was his cumulative exposure over time. This has since been verified in other ways, but basically, here's a close contact. If you're within 6 feet of an infected person for a cumulative total of 15 minutes or more over a 24-hour period, starting 2 days before illness onset, right? Because you can be infectious, or for asymptomatic patients, 2 days prior to the test specimen collection until the time the patient is isolated. Wow. So you can be around somebody for a minute here, 3 minutes there, 5 minutes there. If it adds up to 15 minutes, look out. Things to consider. If they ran up and gave you a hug and a kiss, I don't think you even want to wait for the 15 minutes. That's close exposure. What's the total duration? How does the infected person have symptoms? Was there singing, shouting, coughing involved? You may have read about the study, the choir in Washington State, where they were all sitting apart, but they were singing for 2 hours and everybody got it. Were you indoors with poor ventilation? Was there crowding? So nothing's 100%. The other, in addition to the loss of taste or smell, the one thing I want you to come out with is nothing's 100% with this. I do want to talk a little bit about testing because there's a lot of confusion. So what you want to look at here, so you see on the bottom, you see 0, and that's your symptom onset. And then the numbers, the -2, -1, 1, 2, 3, 4, 5 are weeks. So from the time of symptom onset, you look at the orange there, and that's the rapid antigen testing. That's the one, those are the quick tests. Oftentimes it's not the deeper swab. It can be done with saliva. There are other ways. And you can see it peaks fairly early around the time of symptom onset. And then a week later, it's down to about 0. So that's the rapid test. And then you've heard about the PCR test or the molecular test. They are normally the little bit deeper swab, like what they're doing at BU. And you can see that these will stay positive longer, up to 4 weeks, or in some cases even longer. And this leads to some confusion because it is so sensitive in some cases, some of the tests, that they're picking up little bits of the RNA strand that aren't really infectious, but they're there, but they're still picking up on them. So this is one of these little conundrums with this disease. And then you look at the antibodies, and there's 2 types, the IgM, which is formed early, and the IgG, which lasts longer. And you can see you start building antibody about 2 to 3 weeks later. So that's the antibody test in distinction to the antigen test. This is important. And I really would urge all of you to go to this website and play around with it, because when you're looking at how much risk do I want to take, this is Georgia Tech, put this together. This is updated just about daily. And this is a risk assessment planning tool. So what this does is show you the risk level of attending an event, be it at home or away, depending on how many people. And if you look at the left-hand side of the slide, you see event size, and you can go anywhere from 10 up to, I'm looking 5,000, but 10, 20, 25, you can look at an event. There is something called the ascertainment bias. And remember earlier I said for every case we know about, there's maybe 5 or 10 cases we don't know about. So you pick an ascertainment bias. We really think unless there's widespread testing of asymptomatic people, which there isn't almost anywhere right now, it may be 5. I think it's probably closer to 10. So I just ran the numbers for Broome County a couple of days ago when I made this slide. So think about this. In Broome County on December 2nd, if you're in a gathering of 10 people, and what I used is the ascertainment bias of 5, the ascertainment bias of 10. So if it's 5, there's a 17% chance, or if it's 10, which I think is more likely, 10 people, 31% chance at least one person has COVID. This is based on the data. Let's make it 25 people. Let's get the extended family together. 37 to 61% chance at least one person has COVID. So you can go to any county in the country, any size event, and you can look at this. And when you're assessing your risk or you're trying to convince people, this is the data. This is real. It's pretty sobering. Social distancing. I do want to talk about this in a little more detail. We've all seen this in the stores or in the office spaces, 6 feet apart. There's a lot of different ways to visualize this. You know, if you're in Florida, 1 alligator apart. If you're in Canada, I love this one, 1 hockey stick apart. Maine or Canada, 1 caribou apart. But that's 6 feet, and I'll talk about that science in a minute. But what I really want to say is that masks work when they're worn properly. And again, a lot of misinformation out there about that, but all of you have been out in public, and I think you've seen every variant here. I enjoy this slide. There's some interesting names. So we had the guy at 12 o'clock at Thanksgiving with the schnoz. We've got the sideways, the feed bag, et cetera, et cetera. I love the plague talker. They get up in your face and pull the mask down to talk to you. That's just great, right? And on. But you wear it properly over your face, over your nose and your mouth. And there's been a ton of research. There's people that spend all day in the lab looking at this. Here's just one example of thousands of articles. You know, low-cost measurement of face mask efficacy for filtering expelled droplets. It works. And in fact, this led to an updated recommendation from CDC on November 10th. This was a scientific brief. You can look at it yourself. I like the little doggies down here. Most of them are not wearing their mask properly, but the lower center is. Good for him or her. So here's the science. A tightly woven 2 to 3 layer cotton mask is effective in blocking exhalation and reducing inhalation, both. And they found that it can filter nearly 50% of the particles less than 1 micron. I'll talk about microns in a minute. But what this means, you know, your chance of getting infected is based on your overall health, your immunity, and then the amount of exposure and the duration of exposure. So you're automatically decreasing the amount of exposure. Things to avoid. And you know, sorry, Coach Tomlin of the Steelers and the others wearing neck gaiters and bandanas. They're not as effective. Bandanas, gaiters, not as effective, not recommended by CDC. One of my favorites is those really cool masks. Some of them are N95s and they have those little valves on them. I've been out to Wegmans and seen that. So, you know, people say, hey, this is great. I can breathe great. Well, maybe you can. It's a one-way valve, but what are you doing with a one-way valve that allows exhalation, right? You're just spewing those droplets all over your environment. So please don't wear those. As I said multiple times, full face coverage is vital. And there have been multiple real-world studies confirming effectiveness of this. The thing that's really important in addition to masks is ventilation. Again, I'm going to give you some links here. We'll send this out. Even back in July, there was an excellent article in The Atlantic talking about ventilation 6 months into the pandemic and airborne transmission. This article here was written by Lindsay Marr. I follow her. She's a professor of engineering at Virginia Tech. Her life's work is aerosols and viral spread through aerosols. And yes, transmission through aerosols matters. It's not just the bigger droplets. So this is an important consideration. I'll explain why in a second. In fact, I just read a few weeks ago that there was a gym down in Virginia, where Virginia Tech is located, and they had a case, but Lindsay Marr happened to be a member. So the gym owner consulted with her, and they very carefully, they consulted HVAC experts and ventilation experts and her expertise, and they configured the gym and they improved the ventilation and spaced people out properly, and were able to open the gym and not one other person got COVID. So aerosols are important, and here's why. So remember the 6-foot thing that you hear about every day? That's based on the 1930s, and that's in terms of larger droplets. So if you look at 1, 2, and 3 on this slide, 1 is the larger droplets. You know, the viruses don't exist by themselves, right? They're encased by water and mucus, and they're aerosolized either by the person talking, singing, coughing. I'm sorry to say by toilet water too. But they quickly fall to the ground because of their size. So 1 to 3 feet. And then progressing on to number 2, you know, the mucus starts and the water starts to evaporate. There's less mucus, and these fall to the ground after 3 to 5 feet. So here's where your 6 feet comes. And these can become droplet nuclei, unfortunately. And now the size is less than 5 microns. And here's the problem. Here's the problem. These can float in the air for prolonged periods due to their microscopic size. They can travel much longer than 6 feet. So if you're in a closed environment, poor ventilation, et cetera, you can't depend on that 6 feet and say, oh, just because I'm 7 feet away, I don't have to wear a mask. I highly urge you not to do that. Looking at the left side here, you've heard about filtration, maybe MERV ratings. So a so-called MERV 13 filter, you can see really removes greater than 90% of 3 to 10 micron droplets or aerosols. And you can just see the numbers for yourself. And that's the recommendation of a minimum MERV rating to mitigate COVID. Also, HEPA filters remove almost 100% of particles down to 0.3 microns. So what we recommend a lot of times is if you're not sure about your overall ventilation, get those little portable HEPA filters. They're a few $100s. They are effective, and aerosols are important. This is in China. This is a restaurant in China. So this really endorses the concept of the aerosols causing a problem. So in the upper right, you see the air conditioner blowing out blue. That's air. And you see a gentleman at the middle table circled in black, and that's the index case. So what happened here? They had terrible ventilation. They had this air conditioner that was just blowing the air around and around in a circle. And everybody in red got COVID. Well, he didn't have any direct exposure to all these other people at the peripheral tables. And if you look here, and unfortunately, when they made this slide, it was reversed. So the air conditioner is actually on the left in this slide. And here's your index case in the middle, 15 feet away. And you can see people that had COVID were much further than 6 feet away. So 6 feet is not everything. And I encourage you to wear your mask as much as possible in the indoor environment. 6 feet is not the magic bullet here. Vaccines. So we've heard a lot about it. There have been a lot of updates. I just want to go into this a little bit, as I'm sure it's top of mind for most of you. So a lot of discussion about vaccine trials and, Operation Warp Speed, and is all this happening too fast? Well, let me just explain these trials. So you have three phases. The first phase is a small number of people, usually less than 100, and you're basically just looking for safety. Is something terrible going to happen quickly? Phase 2 is larger, and you start to look more at safety over a longer period of time and also early effectiveness. And phase 3 is the real big, large scale, 30,000 patients looking at effectiveness and longer term safety. Now, it was discussed back very early in the year, 12 to 18 months, we could have a safe and effective vaccine. But, you heard the argument, well, it takes years to develop these vaccines. How can we do this all of a sudden? I will tell you that all the public health authorities, epidemiologists, with very few exceptions that I've read about, are comfortable with what's happening here. And there are several reasons for that. First of all, there's a lot of experience with other coronaviruses, MERS and SARS, and there's been a lot of research done since 2003, actually, on this. These phases are being run large scale and simultaneously. So even though the total time is compressed, the phases are still proceeding the way they're supposed to. And basically, the companies have been financed. They've actually pounded out millions and millions and millions of doses of vaccine before it's even been approved by any authority. And the costs have been covered, basically, and they've been paid to do this. So it has shortened the timeline. Everybody, including Dr. Fauci, are comfortable with this so far. And so, as you know, there are a couple of vaccines that have been approved. And I just want you to understand the difference. This is a new technology. So there are three types of vaccines in development, and most vaccines that you are accustomed to are more like number one, where a protein from the infectious agent is purified. And this, by the way, is the thing that takes years. This is the hard thing to do. So they purify the protein, inject the protein into you, and your immune system produces antibodies. That's a lot of the vaccines that you are familiar with. Number two is the protein is purified, and they'll use an inactivated virus as what they call a vector or an agent to get it into your body in a certain way so that you produce the protein and your immune system responds. But number three is what I want you to be aware of, because both of these vaccines right now that are coming out are number three, and this is a messenger RNA. And on the next slide, I'll go in a little more detail, but this codes for the protein. So this causes your body to make that spiky, you all recognize that coronavirus on the left, those little spiky things, the crowns, the coronas are the proteins. And let me explain this. So this is two different depictions of the same thing. So on the left, so what happens is you are injected with this RNA, and it goes into your cell, and you make that spike protein, and that spike protein then is picked up by the memory cell in your immune system. And then subsequently, if the pathogen gets into your body, the cell says, whoops, here we go, I recognize this thing, and you get a rapid response. And on the right side is more or less another depiction of the same thing. The scientists take part of the genetic code, which builds that spike protein. These are put into a fat droplet, and that's what's injected into you, the patient, and your immune cells make the protein, your body recognizes it, and the immune system produces the antibodies and what's called the T cells, another part of your immunity. And so if you ever meet that coronavirus on the bottom, slam bam, your antibodies and your T cells go into action. So it's the RNA technology that's used for the Moderna and the Pfizer vaccines. And I want to talk about those vaccines a little bit. So there are some differences. The Pfizer vaccine, which is what New York will be getting first, is 2 injections, 21 days apart. Effectiveness is actually closer to 95%, they've determined. The problem is the storage. That's the logistics. Minus 75 centigrade is minus 90 something Fahrenheit. The Moderna vaccine is more, you can put it in a regular freezer. So the Pfizer vaccine is a little trickier, but they're both 2 injections. And then just comparing it on the bottom to the flu vaccine and the MMR, and you can see some differences there. But so we've got this conundrum. So now we're spiking in the US and all over the world. Now we're going to have these vaccines, and how do we run this out? And, how do we do all this logistically? So the National Academy of Medicine was engaged months ago, and they had a number of meetings, public hearings, and they really came up with suggested phases because we're going to have shortages of these vaccines initially. So as you can see, phase 1A is high-risk healthcare workers, first responders, 1B, comorbid conditions, congregate settings for older adults, and you can go right down the line into the phases. Phase 2, K-12 teachers, critical workers, et cetera. Then in phases 3 and 4, we get into everybody else. So, and in the bottom, and they're talking about health equity all through this, because that's really something that needs to be considered all through. So this was just a recommendation. There's a long white paper. Anybody that's interested, I can send you the executive summary, or you can find it yourself at the National Academy of Medicine. It's a very interesting read. So just on December 1st, the ACIP, the Advisory Committee on Immunization Practice of the CDC, met. And what they did is they looked at those recommendations and they had their own discussion, and they talked about phased allocation of COVID-19 vaccines. What did they consider? They considered the science, they considered how do you implement this, and they considered ethics at all times. So the science, you know, what's the disease burden? You're balancing the benefits and the harms of the vaccine. Implementation, looking at the different target groups. Who should we target first? How feasible is it to get to that target? Ethical principles, you want to maximize benefit, minimize harm, and consider health and equity and promote justice. And they did this very compulsively, and this is their recommendation. So phase 1A, they're recommending healthcare personnel and long-term care facility residents. And you can see phase 1 is divided into 3 parts, and you can see on here, essential workers, 1B, and 1C is high-risk adults, 65 plus adults. So the proposed groups for the 1A vaccination, healthcare personnel, of which there are about 21 million. And you can read down the different categories, and then long-term care facility residents, about 3 million. So what about New York State? So we are very fortunate in this state to have an administration that's looking at the data and the science, and they're listening to the experts. And there are now 2 task forces that are very active. One is the Clinical Advisory Task Force. So unfortunately, there's a ton of skepticism out there about this vaccine for the reasons I mentioned. I mean, there are just anti-vaxxers out there. People are concerned about the compressed timeline, et cetera, et cetera. And what the governor has decided is that the FDA is going to look at this, and I'm at this point comfortable with the FDA recommendation, whatever it is, but they're going to do a secondary review. He's assembled a great team, and they're going to look at every COVID-19 vaccine and hopefully build a little bit more public trust. It's been looked at twice. It's been endorsed by multiple experts. And then there's also a distribution and implementation task force. So just the other day, the governor was on, and he indicated that New York will be getting be able to immunize 170,000 people with the Pfizer vaccine. Now, 170,000 New Yorkers means 340,000 doses, right? Because it's 2 doses. But the 170,000, the first shipment is expected on December 15th. And that's what they're expecting at this point. So what does that mean? Well, so you get 170,000 doses, and this will be rolling. So a week or 2 later, they expect another 170,000. But we have in this state 210,000 nursing home residents and staff, and they're first priority for the state. And what the governor said is, well, you know, not everybody's going to agree to take this thing. We want them to, but they won't. So there may be a slight shortfall. They're feeling like probably out of that 210,000, upwards of 40,000 will probably opt not to take it. And then when you look at healthcare workers, I found numbers between 900,000 and 1.1 million in New York State. So you can see we have a ways to go. He does expect to get a shipment from Moderna sometime, hopefully this month, but the timeline's unclear on that. But the logistics, he actually demonstrated the logistics of this Pfizer vaccine. Excuse me. And he had a box, and it's shipped in this box, and the box has dry ice in it. And then there are a number of trays in the box, and each tray has all these vials, and there's 5,000 doses in a box. And it has to be in dry ice, and the dry ice can only be in there a certain period of time. The box can only be open for 60 to 90 seconds. The dry ice has to be replaced after 5 days. So just imagine this. We're running it out across the state. It has to be handled perfectly, or the vaccine will be no good. all right? And we're going to have to get everybody 2 doses at the right time. So you can see this is a monumental logistical issue. And the other issue is if we're going to return to normal or so-called normal or new normal, really 75 to 85% of the population has to be vaccinated. But remember what I showed you about, that was the flu vaccine, right? So this is going to be a heavy lift. It's expected that hopefully we can get there sometime between June and September. And we should probably be into our new normal next fall, I hope. But you know, remains to be seen. It's going to be challenging. And the last thing I want to leave you with is nothing's 100% with this, right? It's what I call the Swiss cheese approach. And if you look from left to right, you know, physical distancing, stay home if you're sick, hand washing, cough etiquette, you know, testing, etc. And you go right down the line, and you got to line up those holes. You know, you got to line up the Swiss cheese, and that's really how we beat this thing. And the vaccine will be the final step here. So good luck to all of us. And what I want to say is, don't give in. You know, it's just a little bit longer, folks. This next few months is the most important time. So I hope this has helped you understand the science a little bit better, helped you evaluate your own risk and make your own logical decisions. And I would implore, take politics out, take emotion out of it, take your COVID fatigue out of it, and just try to look at the data the best you can and make your best decisions. And that's what I have for you today. At any time, feel free to contact if anybody wants to have further discussion. I've been out to several partners to do some presentations for their staff. I'm happy to do that. And with that, we'll end and see if there are any questions. Thank you. And I don't see anything here. So if anybody thinks of anything subsequently, please feel free to contact me. And Alexa, I think what we'll do is, you know, we can send the PDF out to everybody, and it will have all the links on there so people can link to some of these sources. And I think it will make for some good reading.
Sounds great. Thank you so much, Dr. Teris. I really appreciate it. Oh, there is a question that just popped in. Will the antibody test become more accurate?
You know, that's a process in evolution. We don't even know for sure if the antibodies confer immunity on their own. So I guess as with any test, yes, it will become more accurate with time, but I think more importantly, we have to figure out what it means. What does that IgM and IgG antibody mean? Does it mean you're immune, or is it just there? And how long does it take to go away? So it's a piece of information. I guess I'll relate back to my Swiss cheese slide. It's like a piece of information. So, you know, on a personal level, I was really sick back in January. I swear I might have had this thing. And, you know, my wife says, well, go get the antibody test. And I said, well, it doesn't mean anything now, right? If I get the antibody test and I have it, if it's an IgG antibody, it might have been from that. It might not have been from that. I still don't consider myself immune. So it's really, it should be used judiciously and in the context of everything else. Will the military and primary government get the vaccine first? I've not seen that mentioned. It could happen. I've not seen that, although the recommendations thus far have been from the National Academy of Medicine, from the CDC. Now, what the government chooses to do with those recommendations remains to be seen. I guess the other thing I want to throw out there is it's up to each state as to how they manage this. So I saw very interestingly, Colorado was going to immunize ski workers first because they go to these places and they live together in close quarters, and they were going to immunize ski workers before they immunized frontline healthcare workers and people in skilled nursing facilities, and there was an uproar. So they backed off on that. So this is going to be up to each state. Would the military get it first? I could see that happening, but you know, don't know. Okay. I'll sit here for a couple minutes if anybody thinks of anything. If someone had COVID, they should still get the vaccine. Yes, absolutely. Because we don't know if having COVID confers immunity, and even if you have the antibody. So the recommendation is, yes, they should still get the vaccine. How long is the vaccine good for? We don't know. That's going to remain to be seen. The thinking is right now, it may not be like the flu vaccine where you need it every year, but we have to watch the behavior of the virus over time and see if it does what the flu does in terms of mutating. So the answer is we don't really know. It could be in the background like the flu, and you know, more to come on that. Okay. Well, like I said, feel free to get in touch if there's any questions. If, like I said, I've been out to the partners to do some presentations. I'm happy to do that for staffs if you think it would be useful. And thanks everybody for attending.
Oh, Dr. Teris, there's one last question.
Okay, one more.
Should people with underlying conditions jump at getting the vaccine or wait for a second round to see how people react? From a risk standpoint, it's considered risky. Is it considered risky?
It's a tough question. I think probably, you know, they've tested it on people with underlying conditions. In my mind, I would be more anxious to get the vaccine. There's no guarantees. I mean, short term, we know over a period of months, you know, most adverse effects from vaccines occur over the first couple months. Rarely, there might be some long-term thing. So in my mind, people with underlying conditions should probably be first because of this novel virus that is just so deadly to those with underlying conditions. And if it doesn't kill you, it can often lead to long-term effects. So in my mind, from a risk standpoint, it's less risky to get the vaccine than it is to get COVID. Okay.
All right, Dr. Teris, I think that's it. The rest are just things.
Okay. All righty. Stay safe and stay sane, everyone.
All right. Thanks for joining, everyone. Have a great day and enjoy your weekend.
Okay, bye.